Hello, and thank you for joining us for another episode of Together in Parkinson's, our mostly monthly podcast. Today, we're discussing the triple threat of apathy, fatigue, and sleep disorders in Parkinson's. And joining us today is Dr. John Legge, a board-certified neurologist with fellowship training in movement disorders who works out of Eisenhower Medical Center in Palm Springs. Locally, Dr. Legge is known as the only movement disorder specialist serving Coachella Valley. So thank you so much for the work you do, Dr. Legge, and welcome.
Thank you. It's great to be back. Thank you for having me.
Well, over the last few months, we've been having a recurring conversation at PRO's support groups about fatigue, apathy, and trouble sleeping. We've talked about the causes, the manifestations, and some of the treatments of these sleep issues, but they do vary widely. In short, there is no short answer. So I figured it's time to bring on an expert to dive into the complexities of Parkinson's sleep. And Dr. Legge, I'd like to start off with a really broad overview. Can you walk us through, maybe start with how Parkinson's fatigue differs from Parkinson's sleep disorders?
Sure. It's a very important topic because I think this feeds into a lot of quality of life. Fatigue and sleep for definitely a quality of life issue. So, um, I think one way to look at it is sleep is the charger and fatigue's what's happened when the battery gets busted. So, they're different, but they're interlinked. And fatigue can describe, it's daytime symptoms. Whereas sleep disorders, indicate that this is happening more at nighttime, trouble falling asleep, waking up, or not having refreshing sleep. Um, in the fatigue itself, not necessarily as just physical, but it can be emotional fatigue and mental fatigue, spiritual fatigue, interlinked with the movement symptoms as well of Parkinson's. So it can really bring down daytime performance. And then, of course, if you're not sleeping well, that feeds into the problem with daytime performance and more fatigue, and that can be due to everything from sleep apnea to insomnia and a multitude of other things. So, definitely an issue for Parkinson's. The vast majority of patients being affected with one or both.
The way that we often see people talking about this in our groups is I just have trouble getting started. I don't want to, I know I should go to the gym, but I just can't find the energy to do it. Or this feeling that every afternoon they do need a nap. When you get a patient who comes in and starts expressing sentiments like that, what's your first advice for them?
Well, I think it's figuring out what the cause is. So, when we have sudden crashes during the day, that makes me think: are the medications for the Parkinson's that the patient may be taking are rebalanced correctly? When we have perhaps performance issue or fatigue that's accompanied by low mood, sadness, or by anxious thoughts, and worry, that's a different approach. So I think it's trying to distill as best you can, figuring out what may be a primary driving factor, and then getting at any appropriate adjustment to medication or new therapy that you may need. Um, in addition, I would say, we think about medical issues too. Thyroid, anemia come into mind. So, there's also a concern for making sure we've got an eye open for medical causes. And patients are entitled to have more than one thing. So you got to keep an open mind. There could be multiple things at play.
I will say we often play the unofficial game in our support groups. Is it Parkinson's or is it aging? And
Right.
sometimes it's both and sometimes it's neither.
That's right. That's right.
Well, sleep disorders, I've seen stats that sleep disorders may impact up to 75% of people with Parkinson's, and they're often some of the earliest warning signs of Parkinson's. When someone gets a Parkinson's diagnosis, they may look back and start to put the pieces together by saying, "Oh, I had REM sleep disorder for 10 years," or "I've always had a lot of restless nights or insomnia," and the pieces start to fall in place. Can you walk us through some of the early sleep symptoms that are associated with Parkinson's?
Sure. Um, and it is true, the vast majority of patients have at some point, perhaps in their journey with Parkinson's, have some issue with sleep or fatigue. And sleep generally changes can appear years, sometimes decades before the appearance of movement symptoms, what we call motor symptoms, be it tremor or shuffling. Um, it's I think of it as almost the brain's first whisper that there may be an issue occurring, and that's due to the biology of how the Parkinson's is spreading and onsetting in the brain, generally starting in the sleep center first, which is in the brainstem. And then the Parkinson chemical changes spread upwards into the movement circuit, and that's when motor symptoms may start. So that can be years later. You mentioned REM sleep behavior disorder, kind of the acting out of dreams or kicking or self-defense dreams that can happen with talking involved as well. Patients may experience restless legs, kind of creepy crawly sensations in the legs that can happen more in the evening time. And then insomnia, just difficulty winding down and going to sleep and falling asleep or staying asleep, and or some combination again thereof. But so this can, in particular, we found that REM sleep behavior disorder, called RBD, REM sleep behavior, the acting out of the dreams, that's a very strong indicator Parkinson's may be coming, perhaps even 10 or 20 years down the road. So we watch those patients very carefully.
So, if someone is exhibiting the REM sleep behavior disorder, RBD, what, what advice would you give them to prepare for a potential Parkinson's diagnosis? Is there anything they can do to try to prevent that eventual Parkinson's diagnosis?
So generally, how a patient would wind up being followed or get into the doctor for this is they may have a bed partner that says, you're talking a lot, or you've punched me in your sleep, or and so that may happen intermittently. But if it is happening, I think it needs to be explored in the sense with the primary care doctor, who may dive deeper into the symptoms and appropriately refer to neurology or not. And from a neurologist end, when I have a patient that comes to me, and many I follow who have REM sleep behavior disorder and don't have signs of Parkinson, but we know may be at risk of what we understand to be 80% or north. So they're put on a surveillance plan. I may or may not involve sleep medicine to institute appropriate treatment for the REM sleep, but we monitor them clinically, and we do preach lifestyle. What we know is that a good aerobic exercise regimen, and the strongest evidence is for a more Mediterranean-based diet, can slow brain inflammation. And so that can decrease potential progression of the Parkinson, let alone the benefits it has for heart, stroke, and heart disease reduction.
Well, you just said a really interesting phrase to me, which is brain inflammation. I'm wondering if you could take us on a slight detour to talk about how brain inflammation interacts with Parkinson's.
Sure. So it's a hotly studied field right now, and what we understand is that dopamine is not just for movement; it's for sleep as well. And so, part of the progression of Parkinson's, we feel, is that the brain is losing dopamine cells, and when it's under an in dopamine cells, when we lose those, that can bring on the symptoms because we're no longer getting that proper flow of dopamine in brain circuits. And the circuits can get more disturbed by brain inflammation because it causes swelling and a breakdown of natural chemical balance. And that can not only aggravate the symptoms of Parkinson, but can actually accelerate the loss of the brain cells that create dopamine. So um, we're very interested in what's driving the inflammation. We see a very strong link to blood vessel issues, so that of blood pressure, that of cholesterol and blood sugar are very important for inflammation control. So hence that diet and exercise component. And of course, staying on top of those medical issues, again, with your doctor, keeping your blood pressure, your cholesterol, and blood sugar in check.
I know I've read a number of recent studies about the correlation between a diet that's heavy in processed food and Parkinson's, and I feel like you've just kind of put a few of the puzzle pieces in place there for
Sure.
our audience. That diet is it sounds so trite and honestly frustrating sometimes to people, but diet is health and exercise is health and
Absolutely. Absolutely.
pays dividends.
Yes.
Well,
Agreed.
speaking of recent research, there have been a number of articles in the news lately about sleep apnea, indicating that people with untreated sleep apnea have a higher incidence of Parkinson's down the road, but conversely, that people who have sleep apnea and start treating it, that higher incidence kind of drops off. Have you seen that research, and is there anything you could share about it?
Yes. And I think this segues nicely from what we were just speaking about, when we're talking about brain inflammation. So actually, when we've been interested in sleep apnea, uh, that is, and what is sleep apnea? So sleep apnea is states of where the bloodstream deoxygenates overnight. So the bloodstream loses oxygen overnight because the lungs are not perfusing and getting good air exchange into the bloodstream. And so you're not able to get in that good oxygen. And that's because there's some disordered breathing at night. You're not getting good breath flow. You may either have shallow breaths or pauses in breathing where there's long periods or snoring or some combination thereof. And so this can lead to dips in the oxygen level, which, if happens persistently enough, it can cause poor sleep and awakings, and then unrefreshed sleep in the day. We've known that this raises sleep apnea raises risk of everything from insulin resistance causing diabetes to atrial fibrillation and stroke and cancers. But we're seeing in in recent research that treating sleep apnea may slow progression for the
Okay.
Parkinson's. So while this is not a cure, it's an absolutely central protective step. And so if there is apnea, we see oxygen dip. That causes that word more brain inflammation, which can potentially fasten Parkinson progression. So we have seen CPAP in particular, the machine to treat sleep apnea to push air in and reoxygenate better the lungs overnight. Those people that use the CPAP show slower cognitive and movement changes, and in some of the studies. So, what you should know, I think, is that if you have been told or think that you're snoring, and you have daytime sleepiness, certainly we have screening measures, simple, free, fast things you can even do yourself online. Um, and sleep tests at home are pretty easy to get now. So, better breathing tonight can be slower progression tomorrow. So,
Wow. And you know what I find intriguing about that is a lot of our constituents already have Parkinson's and already have some or significant symptoms. And I do get the question, what can my kids do to prevent this, or what can my grandkids do to prevent this? And I didn't necessarily expect in this conversation so far to be talking about diet, brain inflammation, and these, I don't want to call them potentially preventative, but potentially slowness of progression
mhm,
for
mhm.
Parkinson's. But this strikes me as one is monitor your sleep carefully throughout your life the same way you do the rest of your health.
I fully agree. And I do think habits that and I will say a quick diversion. Is the minority of patients who have Parkinson's does the Parkinson run in families, and
Mm.
so generally speaking, the vast majority, I would say, of children of patients who may have Parkinson's, it doesn't run in the family generally. So, um, regardless, I would preach we should be doing those lifestyle approaches anyways, because that's going to be good for your global health.
Absolutely. Well, we've talked a little bit about some of the early signs and
Mhm.
connections between sleep and Parkinson's, but we know that people with Parkinson's are more likely to experience insomnia, to experience restless leg syndrome, and that excessive daytime sleepiness. What can you share with us? What should our audience know about these symptoms? Maybe, what causes them and how do you approach treating them?
Yes. So with insomnia, for instance. So that's a common symptom, and basically difficulty falling asleep, and that with respect to Parkinson's may come from stiffness, motor symptoms like tremor, pain, or difficulty rolling over in bed to get comfortable. And so that may be uh, addressed by adjustments to the patient's medication regimen. Um, Restless legs, on the other hand, is tricky because while dopamine medications used to treat the symptoms of Parkinson's also treats the symptoms of restless legs, but the dopamine can actually accelerate the progression of restless leg symptoms called augmentation or perpetuation. So we do try and not necessarily ramp up dopamine medications, but use something along in the family of gabapentin or Lyrica or something like that, to where we try and avoid. And there are more natural products potentially as well, supplements like magnesium that could be entertained for restless legs. But those that can be a feature. And then you had mentioned excessive daytime sleepiness, which is also the majority of patients may experience excessive daytime sleepiness before the development of a tremor or balance changes, any motor symptoms. And this is basically, we think, due to um, changes in sleep at night, and then changes in dopamine circuits during the day to where patients are not as engaged. And really adjusting the medications for that can help, but we have to be careful. Similar to RLS, the medications that we use to treat excessive daytime sleepiness in some patients can cause more sleepiness. The dopamine agonists that we use for restless legs, especially, are known to cause daytime sleepiness. So I don't want to fix one problem and substitute that patient's problem with another. So it's very much a tailored balancing act, and lifestyle approaches and behavioral changes um, can oftentimes make a difference without trying to lean on pills.
Mhm. So, what type of lifestyle changes would you recommend for dealing with sleep disorders?
Yeah, so timing activities, making sure that you're doing your daytime exercise, and um, group meetings, family meetings and outings. And all of your activities are timed during your peak time, that you're exercising earlier in the day, not too close to bedtime. You're avoiding the alcohol and caffeine. We're eating hours before sleep, and we're trying to practice good sleep hygiene, which is, we're waking at the same time, sleep at the same time, meals are generally at the same time. We're not doing bright lights and tablets and Kindles before bed or TV. We're doing soft lights, music, book reading, low stimulation activities to try and really reinforce the brain to get in that rhythm, where we can reinforce, I'm getting sleepy now and I'm going to start waking now.
That's easy advice to hear and sometimes tough to follow.
Yeah,
um,
I hear
Much
you.
like the diet and the exercise. I mean,
Yes,
but so valuable. And I definitely recognize this in my own life when I'm staring at that screen and doom scrolling until the second I turn the light off, my brain won't go to sleep right
I
away. So.
know, I know, I know. Yeah, it's some of those simple things. I know it's easier said than done, but I will tell you, a lot of these lifestyle changes, the regimen, the rhythm activities, and planning can make a big difference.
Mhm. Let me ask you this. Does RLS, does restless leg syndrome have any connection to neuropathy in the feet?
It can, yes, absolutely. So patients that have neuropathy, which, just to define what neuropathy is, because restless legs is not nerve damage. Restless legs is a poorly understood condition, frequently linked with Parkinson's, and frequently has nothing to do with Parkinson's. It can occur independent, and it may even be related to medication side effect. Restless legs can run in the family. Restless legs can be due to iron deficiency, anemia. There's a long list of things due to restless legs. But with neuropathy, which is nerve damage, and generally speaking in the feet, but it can be anywhere in the body. But when we talk about neuropathy, generally referring to the feet, um, it's burning, tingling, and or a numbness sensation. And for instance, in patients that have diabetes, if they eat perhaps too much sweets at night, their neuropathy may activate or be more burning, tingling, and then their restless legs wakes up. Not only are they maybe their feet feel like they're tingling more, but they've got now got creepy, crawly sensations that they feel they have to get up and walk around. And that's really what we see with restless legs is with the movement. You have an urge to move, and then you have to get up and get out of bed and start walking around, and you get relief, and you can lay back down, and then it may come back again. And so that can be that can be aggravated when the neuropathy is worse. When there's more burning, tingling, then you're more paying attention to your feet, and then psychologically you get the restless leg, and it's a cycle. It can be very linked.
Well, you mentioned sugar, which has me thinking once again about diet and Parkinson's. And I know that it is recommended that people with Parkinson's avoid sugar as much as possible. Do you see any connection within the Parkinson's, within the Parkinson's body and the Parkinson's brain between the consumption of sugar before bed and any sleep disorders?
It is generally not advised, and that's because sugar is stimulating, and stimulant close to bedtime, be it, and there's a long list of chemical stimulants, but sugar is one. It's a quick hit of energy, and sugar can also activate reward circuits, and there comes more dopamine hit, and that can cause an activation or stimulating effect on the body, and that's not necessarily helpful when we're trying to get into that rest and relax mode. So, um, in terms of just sugar in general, we know concentrated sugars and need to be limited because that can contribute to, you know, uh, diabetes and heart conditions, and as again, a risk of repeating myself, and more inflammation on the brain. Here comes stroke or dementia or Alzheimer or Parkinson. So we want to keep that diet piece in perspective.
Yeah. Well, you describe sugar as a dopamine hit, and I get a question a lot at our support groups about, oh, if I'm having trouble falling asleep, can I skip my last dose of medicine or take it a little bit later, take a half dose? Of course, you can. I cannot answer that question, and you cannot answer that question without talking to the patient themselves. But what can you tell us about the timing of carbidopa levodopa and how it might impact sleep? Because it's essentially creating or imitating dopamine in the brain.
Correct. Yes, and timing is key with carbidopa, levodopa, and sleep. Generally we do think about late the last dose of the day if there's a wearing off effect, that could create more stiffness and slowness, more pain or frequent wakening overnight, difficulty rolling over in bed, or if there's a need to urinate, there may be difficulty getting in and out of bed and shuffling. So um, sometimes, we do have to give a dose of time active, time release dopamine at night, continual release. Or however, at the same time, if you're too aggressive or have too high of a dose of the dopamine at night, or too high of evening dose even, it can peak overnight during sleep and cause vivid dreams and restlessness, and certainly, activate those dopamine circuits to cause REM sleep behavior disorder and more enactant and self-defense dreams. So we want to be flexible. Levodopa is not just for the motor symptoms. Has its effect on sleep and has to be used judiciously.
Mhm. We talk a lot about, we have talked so far a lot about sleep and the things that keep you from sleeping and the things that keep you from sleeping well at night. One aspect of Parkinson's that isn't quite a sleep disorder, but may prevent good sleep is nocturia, or the frequent urination at night. So I'll just use this opportunity to remind our audience that the most common time for a fall is at night, and the most common location for a fall is the bathroom. So even though you're tired and sleepy and maybe don't want to turn on the lights and activate every circuit in your brain to get through that nighttime pee break, it is a time to take great care and consideration with your actions. Make sure you have a well lighted hallway to the bathroom. Make sure you've got slip proof flooring in the bathroom wherever possible, just to reduce that fall risk, because night times are essentially fraught with danger when you have a balance disorder. We mentioned a few times also the impact that this can have on the caregiver if you're talking during the night or punching out or kicking out during the night. Dr. Legge, what advice would you give, or do you give, to caregivers who are also experiencing interrupted sleep because of their loved one with Parkinson's?
Yes, I think we start simple and then kind of layer up. So, we do want to try and get to the cause of what that sleep disturbance may be. Is it more wearing off symptoms and we need a levodopa adjustment? Is it more sleep apnea and snoring that's keeping us up? Is it more REM sleep behavior disorder and movement? Based on that, we may start more time release dopamine at bedtime, or we may get in for a sleep study and get a CPAP going, or we may start some melatonin or a gentle tranquilizer at bedtime to help the REM sleep. We think about medication and intervention adjustments, and then the environment in the bedroom. We want to make sure that we're following good sleep hygiene. We're using, if there's need for, we're making, particularly for REM sleep behavior disorder, we're making the bedroom environment safe. So if there's been a history of injury, either to the bed partner or self-injurious behavior, that, we clear that nightstand of sharp items. We may have padding near the ground by the mattress. We may have bed rails. And then truly, if it isn't a safety issue, we do have the bed partners sleep in a separate bed to where they may not be injured, but they can still be accessible to help. Um, and I think we do try to make sure the caregiver is getting adequate sleep, because your family and spouse, loved one, that because this is, as it's a group effort, and sleep is so essential. We spend as humans a third of our life asleep, roughly.
If we're
So
lucky.
if we're lucky, 12 months out of the year, 3 months, 3 to 4 months we're asleep for. So it's remarkable how important it is. So we really want to focus on good quality and tailored intervention for that patient, because that's going to help the loved one.
Yeah. I'm wondering, because you mentioned a few sleep aids like melatonin, are there any commonly prescribed or commonly taken sleep aids that you would advise against for people with Parkinson's because of Parkinson's medications or interactions it could have in the brain?
Yeah, so the best evidence, there's a variety of options, but the one of the most common we use for REM sleep behavior disorder over the counter is melatonin. Doses, bigger doses too, up to even 12 milligrams, perhaps higher. And we frequently use for REM sleep behavior disorder the medicine that's got the best evidence. And so that's what we prescribe, because that's what we know has the strongest data, is clonazepam. Clonopin is for the REM sleep behavior disorder, where melatonin may not be doing the full job. Um, Trazodone has a role as well, and potentially Seroquel and other meds. But we really want to stay away from over-the-counter medicines, like Benadryl. That's diphenhydramine, doxalamine. And so this is another Benadryl type medication. So these are found in blank PM products, so Tylenol PM or Advil PM. And so you've got to look at the back of that bottle and just call the doctor, um, team, and see, is this safe? Because generally speaking, we avoid those medicines because they raise risk of cognitive clouding, and they've been studied to raise risk of falls, and they can cause bowel and bladder problems, retention, and difficulty with swallowing, and a manner of things that in the long run, have safer options then. So that's we again, just to repeat myself, Benadryl, diphenhydramine, and doxalamine are common PM sleep aids over the counter that we would want to avoid.
Well, I'm really glad you shared that with us. That's really good to know, and we'll make sure to highlight that to our audience. I promise I'm going to let you go soon. I have just a few more questions. One
Sure.
thing I wanted to touch on, and actually the last time we talked, Dr. Legge, we talked about hallucinations and delusions. And I know that anecdotally, a lot of our constituents tend to experience things along these lines more commonly at night. Can you talk through why that might happen and how you would approach that in your own patients?
Yes, so we know that there's a variety of different brain circuits that activate as as we're going to sleep, and so when there's different, in particular, serotonin and dopamine circuits that are changing, basically when we sleep, the brain goes through different periods of slowing and then speeding up again, and actually during periods of dreams, the brain is quite active, and you may be chasing a ball, or golfing, or you may be in the supermarket in your dream, and pushing and reaching for something, and with REM sleep behavior disorder, the parking brake comes off, and so you start moving in your dream, and so that can create a safety issue. Um, we we basically see, with the sleep changes in the circuit on EEG that we've studied, that Parkinson's and other neurodegenerative disorders don't have regulated sleep patterns. And so a lot of the medications we have and interventions we have are trying to restore more normal circuitry. And hallucinations tend to happen because the brain activates patterns and circuits that should be more awake during the day, perhaps. And so we start now seeing patterns in people and shapes in environments that we shouldn't have. We should be asleep in a dreamlike state. Now we're awake. We awaken. We're semi-conscious, and we have spillover of some dream circuits activating, generating images that should be reserved for different times. And now we have awakening state, and patients may briefly feel that they're hallucinating and then they resolve overnight. I will say also, we see a big overlay between REM sleep behavior disorder at night and hallucinations during the day. And so, as we spoke last time, hallucinations are more reserved for daytime events. When patients say I'm hallucinating at night, they may more mean REM sleep behavior disorder. And that's going to be a very different approach to treatment.
Interesting. So they might actually be almost misnaming what they're experiencing. They,
Yes, because hallucinations, again, are similar to REM sleep behavior circuits, but now they're activating during the day, and I'm now seeing and s- smelling or hearing stimulus, people or shapes or sounds that are not there. That's a daytime event, and that's an hallucination. And I get the word, it makes sense that you'll wake up overnight and hallucinate, and you're interacting with something or talking to someone or yelling at someone or doing something that seems like an hallucination. But if that is during sleep, it's better term is called REM sleep behavior disorder, and that's more melatonin and treatment like that. So it is a different approach. But again, they can frequently overlap.
okay. Well, is there anything we haven't covered about sleep disorders and Parkinson's that you think the audience should know?
Well, we've covered a lot. I think it's been,
I think so too.
a wonderful conversation, and thank you again for having it. As I mentioned at the beginning, these are big quality of life issues. But I think tailoring a plan and starting simple and then layering it up, as I mentioned earlier. We want to try and get the most relief with the least amount of pills first.
Yeah.
And so that's going to be lifestyle approach, sleep hygiene, wake and sleep times are set, meals and meds and exercise time. We may think about sleep diary. What's causing my sleep problem? Is it more stiffness or need to urinate? Is it insomnia or snoring? Is it active dreams and self awakenings from the REM sleep or pain? So you try and figure out a checklist, try and get to the root cause, reinforce that sleep hygiene, get good medication timing, really kind of dial that in like a radio, the levodopa, the other meds. Add melatonin and other agents as appropriate. And then we consider other medical issues that may be at play. And we may get our colleagues in sleep medicine involved, to help manage any sleep apnea or some other issues that they could help us with as well for optimization of certain medicines. So there's a lot we can do, but I think a tailored approach is, with most things, is best.
Yeah. Well, it's Parkinson's Awareness Month. So while I've got you, I'd like to ask you, what's one thing you wish more people knew about Parkinson's?
Well, I think, just what I just said, actually, I think is a tailored, customized approach, that puts that individual goals, symptoms, lifestyle, patterns and behaviors at the center and customizing it. Because while Parkinson's can have big quality of life issues, there are many options abound, and we can have a big jump in performance and happiness and satisfaction and thriving by really tackling individually symptoms and tailoring it for that person and fitting their lifestyle, because you can get good quality of life even with big symptoms like fatigue and sleep changes.
I think
Um,
that word you used, customize, is so
yeah,
important. And and hopefully that is a source of hope for anyone living with Parkinson's, that you become, when you have Parkinson's, you almost become this science experiment, that you are the scientist and you are the subject at the same time. And there's this constant tinkering to be done. At the same time, there's a lot of work to be done, that there's an investment of labor into your own exercise, into your own diet,
yeah,
into your own routine, into your household, to make sure that it is as, safe and comfortable and life sustaining as possible.
right.
It is a massive undertaking. And
Agreed.
if you pursue it with a good amount of openness, curiosity, and effort, you do see these massive leaps in quality of life. So that should hopefully be a source of hope for people. The more work you put into treating your Parkinson's, the more results you'll see.
Agreed.
What else gives you hope in the current landscape of Parkinson's treatments or cures?
Uh, it's a very exciting time. I think we've mentioned a lot about new research with sleep apnea that's coming out. We've mentioned the interest in brain inflammation. There's just to touch on something recently, um, of stem cell therapy replacement. Just the world's first. Just a few days ago, in this month, March, Japan was the first to launch to approval the first regenerative medicine for Parkinson's, granted in a small trial, but this had significant results for these patients, and so they have moved forward with their technology for stem cell replacement for Parkinson's. We're entering, I think, a new era, and so these things are no longer in the windshield. They're starting to be in the rearview mirror now, as we've started to hit milestones in beyond proof of concept that um, anti-inflammation and antibody therapy, small molecule and stem cell replacements, that these are starting to yield results. So I think it's a very exciting time. Um, and I look forward to seeing what we have indeed in the next 12 months as a readout in some of these big studies. Because we've got a lot of hope on the horizon.
Well, I think that's a wonderful place to end. Dr. Legge, thank you so much for your time today. I know you already had a very long and full day treating patients, so we really appreciate you sharing your knowledge with us. And
Pleasure.
for our subscribers, don't forget to subscribe to our channel so you can get the latest information about Parkinson's. We have so much more where this came from. We're here to help you navigate life with Parkinson's. You are not alone, and hopefully after this conversation, you are with hope. So we will see you next time, Dr. Legge. Thank you again.
Thank you.